It's very interactive, so if anybody has any questions, please do just jump in, put them in the chat, and I'll relay them back to Nigel. So this month we've got our very own Nigel Chan, who's been instrumental in helping me set this up. He sends you guys all the emails, so he's very familiar. And Nigel's been embarking on his POCUS journey for about the last 18 months and is undertaking some work at the university. So I'm sure he's got some really interesting cases. Take it away, Nigel.
Right, cool. I've also got some of my colleagues in the room, so if they ask anything, I'll try to relay it back just for people online. So for those who don't know me, I'm Nigel. I'm one of the grid trainees in Glasgow, and I've entitled this talk A Beginner's Guide to POCUS and the PZD. Hopefully both in terms of for people who are maybe a bit new to doing some scanning, but also I would probably still consider myself a beginner, so it's kind of in both terms. So in terms of what we're going to be hopefully going to talk about in the next kind of 45, 50 minutes, I'm going to touch on a little bit about how I got started doing scanning. We're going to talk a little bit about basics, just for people who've maybe not done any before. Hopefully this will be a bit more of a kind of entry-level talk. And for anyone who's done a bit more scanning, please feel free to either type in the chat or ask questions and comment on the scans. I'm going to give you some of my top tips that I've think are useful over the past kind of year that I've been doing it, and then most of the time will be spent going through some cases where we'll talk briefly over the kind of how to do the scan and a little bit about the evidence base regarding it. I think most of the modalities I'm going to cover have actually been covered in previous talks, so I'm just going to touch on them quite briefly, but if you want to, delve a bit more, then just go back and look at all the recordings. So for any pediatricians on the call or in the room, you've probably all done some ultrasound scanning, whether you like it or not. So when I first started training as an ST1, we all did cranial ultrasound scans, and it was basically our jobs on a night shift to do all the day 1, 3, 5, 7, 14 cranial ultrasounds for all the preterm babies. And when I was actually preparing slides for this talk, thinking back on it, is actually a bit nuts that was our job, because the training that I got was basically, this is how you turn on the machine, this is how you save a picture, these are the pictures you need to try to get, good luck. And actually this facial expression is probably quite apt to how I felt at the time. I think it's very much probably not what point of care ultrasound should be. I think from my point of view, doing POCUS should be helping us to answer relatively easy questions. I'm not trying to do a job of radiologist. I really feel it's our job to be grading hemorrhages 1, 2, 3, 4 and commenting on PVL and all that kind of stuff. And the brain is quite complex anatomy as it is anyway. Whereas from my point of view, it should be, an extra piece of information for my clinical assessment. And ideally, whenever you're doing a scan, you should have an idea of why you're doing it and what the question is you're trying to answer. I have a bit of an expectation of what you're hoping to see. So, I mean, hopefully things have moved on a bit. I'm not sure. I'm sure new PEDS trainees probably still have to do a lot of this stuff with a lot of training. But after that, I didn't really do much more ultrasound stuff during the rest of my kind of PEDS training. And then when I first started my subspecialty training about 2 years ago, to be honest, I was just trying to find ways to use up my study leave, my study budget. And I came across a one-day PEDS ultrasound course in London that I went to, which was interesting. They went over stuff like fast scanning, basic echo, IV access, stuff like that. Someone on the course has signposted me to something called the Cactus course, which is a bit more PEDS focused ultrasound stuff that's run by the Intensive Care Society. So I did that about a year ago. At the moment, I think I still need a lung module that's there. And that was a good kind of introductory to how to use the machine and getting used to looking at scans and stuff. But to be honest, from an ED point of view, most of the children that we see from a lung point of view are just wheezy. And doing a lung ultrasound, I mean, I rarely get a chest x-ray for the kids I see anyway, so there wasn't actually a huge amount of opportunity that I was scanning people day to day. And I've just included this here just in terms of our kind of PEM subspecialty curriculum. POCUS is mentioned twice under the kind of technical skills bit. It mentions about doing these kind of things, but that's kind of all there is. There isn't really much in terms of how you go about getting competencies for doing this or training. Whereas, you guys here who are RChem trained, it is part of your curriculum now, and there's a bit more guidance about getting proficiency at doing your kind of fast scans and your basic echoes and stuff like that. So that was probably about a year ago. And then about a year ago, I met Dave at an RChem conference when he was giving a POCUS talk. And actually found it really interesting that what he was talking about and the stuff that he was scanning for in ED. So, scanning for injuries, scanning for joint effusions, scanning eyes for ICP and soft tissues for foreign bodies and stuff like that. And I got chatting with him afterwards, and he probably very kindly just said, "Here's my email, please keep in touch," thinking I'm never going to see this guy again ever in my life. But fast forward almost a year later, he kind of signposted me to doing the postgraduate qualification, which I've done pretty much, just waiting for kind of final assessments to come back through T-sides, which was kind of a specific POCUS qualification. And we've helped set up this platform as to kind of hopefully bridge that gap in, the kind of formal training for PEM people in POCUS. And I think we've actually managed to get over 700 people sign up from mostly the UK, but actually from all over the world, which is quite amazing, actually, when thinking about it. And just as a final plug for if anyone happens to want more kind of CPD, the P2 network are the American guys who meet weekly on Thursdays at 6 p.m. UK time. They do a 1-hour teaching session with speakers again from all over the world, and the P2SK are the Canadian group who meet on Wednesdays at 2:30 every week, and they're both free virtual teaching. So I can, if anyone wants more information, I can signpost you to them. So just one slide on kind of basics in ultrasound. So you might come across this awful term called knobology, which I think is ridiculous. But in terms of, looking back, whenever I first started cranial ultrasound scans, if someone had actually sat me down and told me how to use the machine and what all the different buttons do, I think this is the kind of bare bones minimum that you'll need to take from this. So this is a picture of the machine that we have here for the guys in the room. And just in terms of what I think is, if you've never done any scanning before, these are the basic things that I think you should know what you're doing. So in terms of choosing which probe to use, so there's the linear transducer here. Can everyone see that? Well, yeah, you can see that, yeah. So this is called a linear or high frequency transducer. So basically this is used for things of less depth, but you get better detail. And a curvilinear probe, you can see the footprint is a bit wider. So this is good for scanning things that are a bit deeper, but you get less detail. It was kind of bare basics that you need to know. So for us in PEDS, most of the time you'll get away just using a linear high frequency transducer, unless you're scanning like a teenager or something, or someone more adult size, and you're doing an abdomen scan or something, you might need to use this. And this is a phased array probe, which is a low frequency transducer used for mainly echo or head scans, just because it's got a smaller footprint. It's worth also just knowing where to orientate yourself on the screen. So every transducer should have a notch or something on one of the sides, and that corresponds to the left of the screen. So just so you know where you are. And if you don't know, just stick a bit of gel on one side and tap it just to see where you are. Not so relevant to our machine, but if your machine has different presets for different modalities of scanning, use them, because the manufacturers have programmed lots of clever physics to optimize your image for that application. So if you're scanning like a soft tissue, put it on an MSK preset, or you're doing a lung, put it on lung preset. Our machine doesn't actually have that, but if you have that, use it. And then from a kind of basic controls point of view, find out how to adjust the depth and find out how to adjust the gain which is the brightness, basically. And I put this thing called TGC in focus, just in asterisks, because again, not all machines will have these, but for our machine, there you can adjust the focal point, which looks like two little egg timers on the sides. And again, just adjust that to the bit you're actually interested in, because it'll make your image as clear as possible. And TGC stands for time gain compensation. So in older machines, it looks like this like little nozzle of different controls. And the best way that I can describe how it works is basically, imagine you're in a car, your kid's in the back, and you're sick of listening to the Frozen soundtrack for the 1000th time in a row, but you want to turn the volume up in the back, but not the volume up with the whole car. Then you basically just adjust the sliders. So the sliders at the bottom of the screen is the brightness at the bottom of the screen, and the top of the screen is the top. So if you wanted to make the volume louder in the back of the car, just turn the sliders in the bottom up. But to be honest, if you don't know what you're doing, just stick it all in the middle and don't touch it. This is a good way to go. And lastly, find out how to save images in terms of actually freezing them, taking screenshots, taking videos, and how to store them in your machine and take them on a memory stick, or if it's really old, a CD drive like R1 has. And so these are my top tips. So the first one is probably the most important, I think, for anyone who has either not done any scanning at all, or maybe you have come along to some of our talks but not done any scanning, or you've been on like a one-day course a long time ago but then never did any more scanning. You've obviously hopefully gotten interested to it. I would encourage you to just find your machine and just scan patients. Do it in your non-clinical times, do it when you're not on the shop floor as a kind of educational thing. Ultimately, it's a technical skill. You can read it as much as you want about how to put in a cannula, but until you actually pick one up and do it, you need to get a feel for it. And it's the same with doing ultrasound. So you need to get a feel of how to hold the probe properly, how to get the best quality picture you can get, because ultimately, if you've got poor information, you can't really interpret it very well. So as I kind of touched on in the beginning, every time you're going to do a scan, think, why am I doing it? What's the question I'm trying to answer? Don't just scan something for the sake of it, because you might find something that you don't know what it is. And that happens anyway, but as long as you recognize your own limitations as to what you can do, the kind of optimization of the images is really important, because if you've got a really poor quality image, you're not going to be able to make heads or tail of it. Keep it simple. So the bare basics: does it look normal or does it not look normal? And if you're in doubt, if you're scanning like an elbow, scan the other one just to see what normal looks like, and then scan the other one. And ultimately, as I said, is not to replace getting a CT or getting a proper radiology scan, but it's just to help me have a bit more information whenever I'm trying to make a decision about what to do with my patients. So, we're all taught to look, listen, and feel. So whenever we're examining someone, we listen, we feel, but why not also have a look with an ultrasound machine? So we're going to go, just to keep an eye on the time, we'll go over a couple of cases. So the elbow is a good place to start. It's probably where I first started after doing the kind of lung stuff. It's a pretty common presentation. We see kids come in with arm injuries. It's not a difficult scan to do, and it's pretty easy to interpret. So at least speaking from my experience, and hopefully this rings true to some other people in the room, but I'm sure you've all been, tasked with trying to see a kid who has been picked up from nursery and they're not using their arm. There's no history of any injury. And as soon as you go anywhere near them, they just start screaming in your face, and you don't know where they're sore, if they're sore. And are you going to x-ray like their whole arm and get really suboptimal views of each bone anyway? Or are you just going to do nothing at all? So the idea of adding point-of-care ultrasound to help narrow down your differential diagnosis has been a huge game changer for me. Well, obviously, if you've come in, you've got someone who's coming in and their arm is obviously deformed or bent, I'm not going to start messing around and scanning that. But it's for the ones that you're not quite sure about. Or if someone who you think might have a pulled elbow, or you're not sure, but the history is not the classic kind of history, can help you make that diagnosis as well. So, is a 3-year-old boy Triage is a right arm injury, fell off a couch, unwitnessed, not really much else to say. Looking at him, it doesn't look obviously deformed. He seems a bit sore. He's just basically sitting with his arm and he's not really moving it. So we're just going to very quickly go over how you do the scan. So basically the kind of POCUS question I'm asking myself whenever I'm scanning someone's elbow is basically, do they have an effusion or not in the joint? So if they have an effusion, then it's, it's a secondary marker that there's been an injury somewhere in the joint capsule. If they don't have an effusion, it's going to be very unlikely that they've fractured anything within that joint. And it makes me not worried about the elbow and examine other bits of their arm. So it's just a kind of schematic of what we're probably used to looking at on X-ray. So you're looking for that, posterior fat pad elevation from a lipohemarthrosis within the joint. And obviously ultrasound is really good at looking at soft tissue and fluid. So hopefully I'll demonstrate to you that it's a lot easier to detect that rather than doing it on an X-ray. So in terms of how you actually go about doing it, so forgive the retro iPod mini. I don't have my own transducer. But you basically take two views of the elbow, ideally in this kind of flex position as much as you can. Obviously, it depends on how uncomfortable your patient is. So you're not doing anything that you wouldn't be doing if you're X-raying them anyway, because you ideally want to get them in that kind of position to get a proper AP and lateral view of the elbow. So you want to take two views. You want to look in a long axis, and you want to look in a short axis this way at the olecranon fossa. And so this is basically how you do it. And again, if you want a bit more detail in it, Dave did a talk, I think it was one of the first talks about upper limb injuries. You can go back and have a look at that. So this is what normal looks like. So if you take nothing away from this talk, just get an idea of what normal ultrasounds look like, and then you can kind of work your way around everything else from there. So this is just the same picture, just rotated 90 degrees. And this is a corresponding picture on ultrasound. So the top, so this is the high frequency linear transducer. This is the focal bit that I was telling you about, the egg timers. So this is set at about 3 centimeters. This is skin, soft tissue here. This is the triceps muscle here. You see all the muscle fibers. And this bright hyperechoic bit is the bone. So this is the distal humerus. And then this is the olecranon fossa here. So basically just this on this picture. And what you're looking at, this kind of more gray blob here is the fat pad. And that should sit nicely within that groove. So I think this works. If you draw a nice line here, it should sit underneath it. Okay. So that's what normal looks like. And this is just rotating your transducer 90 degrees, looking at it in a short axis. So again, skin, soft tissue, this is the lateral epicondyle medial, and this is the groove, and this is the fat pad sitting nicely within that fossa. Okay. So that's what normal should look like. This was a systematic review meta-analysis published in 2 years ago, 2023. So they included 8 studies, had almost 1,000 patients, and they showed pretty good sensitivity and specificity for using ultrasound to detect elbow fractures in kids. There's links to all the references at the end if anyone wants to have a read themselves. So back to the case. So this is the kid. So as I said, normal or abnormal? Just have a look. Yeah, abnormal. Okay, so you can see here the triceps muscle is pushed up, is bulging. This is the fat pad here, and this more dark hypoechoic is the lipohemarthrosis pushing it up. And this is it in short axis. I don't think this is a clip. This is a picture. But again, you can see this is all bulged and pushed up. So if I see that, then I'm going to get them an X-ray because they've probably fractured something within their elbow joint. Okay, and this is the corresponding X-ray. So I know that's probably quite small on the screen, but at first glance, it doesn't look like there's anything obviously wrong with it. And it's hard. I mean, it doesn't project very well there, but I mean, I would say it's much harder to see a posterior fat pad there than what I just showed you in my ultrasound, in my opinion. So this is a 4-year-old girl. Her left arm was a soft play. No one really saw what happened. Looks all right. Doesn't look bendy or anything. She's not moving the arm, and she's basically holding it like this on her side. So normal, abnormal. Not a trick question. Abnormal.
Abnormal.
People in the room are saying abnormal. Hopefully people in the call can appreciate that. So this is a very similar picture. So again, high frequency linear transducer set at about 3 and a bit centimeters. Focal point is set by here because this is the bit I'm interested in looking at. And you can see nicely there's an effusion here and in the short axis. And this is what her X-ray looked like. So it's a bit more obvious in this one. You can see a posterior fat pad. You can't see any obvious break though. But she was just treated conservatively for a Gartlett 1 basically. This one is a 3-year-old boy who, so the story was that basically the parents were taking him out of his car seat, and apparently he was just really eager to get out of it, and his arm may or may not have been stuck on the kind of seat belt, and they basically just grabbed him out. And they were worried that he had hurt his arm because he didn't seem to be moving it as much. So again, nothing really obvious to see looking at it. And he wasn't moving it basically. And if you went anywhere near him, he would basically tell you to go away. He just was screaming in your face. So, so start off same approach. Have a look at the electron see if there's an effusion. So it's probably not quite on axis here, but that looks normal, relatively normal. Definitely in the short axis view, there doesn't look like there's an obvious effusion here. So I saw that. It made me much less worried that he'd fractured something within his elbow. So the question was, why is he not moving his arm? So pulled elbow. So everyone who does PEM loves pulled elbows because it's a quick fix, and you feel like you've actually made a difference to your patients, and it feels good, which is great. But you don't always get the classic story of a good pull and they're not using their arm. Sometimes you won't get any story and you're not really sure. But obviously what you don't want to do is start manipulating someone's elbow when they've actually fractured it. The classic, I think even in our guideline, it says, clinical history examination, if you're still not sure, X-ray it. And really you're X-raying just to make sure there's not a fracture. But my argument would be, why don't we just ultrasound it first and then save them getting an X-ray if you don't need it? So in terms of how you scan for a pulled elbow, you see Hannah's getting a bit more annoyed here. But this is the kind of view you're looking at. So you're scanning the radiocapitellar joint basically like this on the arm. So like here. And the probe marker here is towards her head. So it is left of the screen. So this is the distal humerus and the capitellum here. And this is the radial head here. And this is a kind of corresponding picture, what you're looking at. The bit you're interested in looking at is this bit, which is the supinator muscle and the synovium here. Okay, so the supinator muscle is attached to the radius as well as the annular ligament. So when it's pulled, obviously the radius goes down that way, but the muscle is still stuck to both bits, so the annular ligament and the radius, so it gets pulled and stretched out. Okay, and you're basically just looking for that on ultrasound. So if I go back, you see this muscle belly here is nice and tapered, goes to a nice point. Whereas when it's abnormal, it's all blunted and stretched, and the synovium gets pulled into the joint space. And that's what it looks like. Okay, it's called a hook sign. It's called a J. It's got lots of different names, but I call it a hook sign. And that's what you're looking for. It's really as straightforward as that. So this was actually the patient I was telling you about. So he had a pulled elbow. From an evidence point of view, this was a paper published 2021 using ultrasound to diagnose pulled elbow. And you see, I mean, you can't really get better sensitivity specificity than that. And they had over 200 kids in their study. So this is just kind of a schematic diagram of how I approached pulled elbows now. So as I said, if they're obviously a pulled elbow, then fine, they're pulled elbow. If you're not sure, then scan the elbow to look for an effusion. If there's an effusion, they don't have a pulled elbow, X-ray them. If you don't see an effusion, have a look at the radiocapitellar joint to see if they've got a pulled elbow. And if you reduce it, that's great. You can also rescan it just to see that that sign will normalize. And again, if you're not sure, scan the other elbow, the normal one. Hopefully, I know Dave had a case where both elbows were pulled, but that's probably once in a lifetime. But and also, it's actually useful to scan their normal elbow first, because half the battle in scanning the kids is actually just getting them on your side, because they'll be a bit nervous and a bit scared. And if you can demonstrate what you're going to do on the arm that isn't sore, then it hopefully gets them a bit more used to what you're going to do. So this is a young baby, so 5 months old. It's a bit wordy, but so basically, long story short, he was doing some tummy time and he got a bit stuck in his front. So his mum went to pick him up to put him on his back. And she was worried that when she picked him up, his arm basically got caught under him. And she worried that she twisted it and broke his arm. Because he didn't seem to be moving it. He seemed a bit upset when he touched it. So nothing really to see in examination. I mean, it's hard in babies that age because they're all a bit chubby anyway, but there wasn't any obvious deformity. I didn't actually see this patient initially. It was one of my colleagues who saw him. And again, she wasn't really sure what was going on. So basically x-rayed everything. Okay. So this is what he got. So basically the whole arm got x-rayed. And I'll save you the pain, but basically it's normal. Well, anyway, it looked normal to me and to my colleague. So she wasn't really sure what to do. So the plan was to have a chat with ortho. Now, this was actually like 1 a.m, and there was a trauma call at the time, and ortho was at the trauma call. And I was actually finishing my shift, but I thought just for funsies, I would scan the elbow and have a look. So the same kind of approach that I described, have a look for an effusion. So normal, abnormal, people in the room? Normal? Yeah. Yeah, I agree. Looks fine. So again, you can see there's not the, I mean, kids really, they don't have a lot of muscle blocks, so you get really good quality details with the transducer. But yeah, that looked normal to me. And then this, so the right arm was the one they were worried about. So I scanned his left one first. So to be fair, it does look maybe a bit blunted and a bit tapered, but actually if you scan the one that was affected, you can see the difference, hopefully, of this muscle here is completely stretched and pulled in. And once I saw that, I basically reduced his elbow, felt a click, and he was fine. So that saved him, waiting hours for an orthopedic surgeon who's probably never done any PEDs to come see him. I'm not even sure what they would have done anyway. But that was a big win for me. And then this one is a 2.5-year-old who was basically picking up an Amazon box, apparently, and then dropped it, and then was complaining with sore arm, was the story. And again, I didn't see this kid initially. It was one of my colleagues who saw him. Thought it was pulled elbow, reduced it, and did the usual thing we would do, basically go away for 10-15 minutes, go back, and hopefully they're moving their arm. Unfortunately, that didn't happen. So he came back, but he was still just had his arm to the side and not using it. So I scanned his arm. So these pictures are not quite as good. So this was scanned using a handheld butterfly probe, but even though the image quality is not quite the same, you can still hopefully easily see that there is a clear effusion here in his elbow. And he basically had a fracture. So unfortunately, he had a suspected pulled elbow that wasn't a pulled elbow. Any questions? Anyone? No. I think this is the last elbow case, so it's a little bit different. But a 12-year-old boy who has got sickle cell disease had his pneumococcus vaccine 2 days before presenting, and basically had progressive swelling and redness of his left arm, basically, and was a bit hot and a bit red, and he wasn't really moving his elbow as much. Again, I didn't see this patient initially. One of my colleagues who saw him. He got some imaging done, some bloods. So his inflammatory markers were up. You can see there's a lot of soft tissue swelling on the X-ray, but actually the bones themselves looked fine. So the question was, did he have a septic arthritis of his joint, or did he just have a cellulitis? And I think this was actually over a weekend, so we don't have as easy access to get radiology scans on weekends. And they'd asked the orthopedic surgeons to come and have a look at him. But I basically overheard this. I thought, why don't I just scan his elbow to see if there's an effusion there? And this is what I saw. So looks a little bit different, but in terms of looking at the actual joint itself, so this is soft tissue, which looks very abnormal. This is his triceps muscle. That's his distal humerus here. That's the fossa here, and that's his fat pad. So there's no effusion here in the joint, you can see. But this is basically what cellulitis looks like on ultrasound. So it's called cobblestoning, and you're basically just seeing inflamed tissue with kind of inflammatory fluids, which is this black stuff that looks like that. And if it progresses, you'd see an abscess. If it gets really bad, you'd see free air, which hopefully you'll never see if it becomes neck flash. But that I was very confidently able to say he definitely does not have a septic arthritis at that point. I think he actually ended up getting a Doppler ultrasound over the next couple of days, and he had a clot in his basilic vein, probably, which was the cause of his cellulitis of interest. So we've got to move on to a different part of the body. So other than the elbow, hips are probably a good place to start if you've not done any scanning. Again, there's a relatively common presentation that we see kids who come in limping without any trauma. Obviously, there's lots. The differentials for kids who limp is massive. Can be anything from malignancy, infection, nothing, or lots and lots of other things. But the idea of using point of care ultrasound is to help narrow down your list of things, and hopefully, you can avoid doing bloods. And otherwise, someone who looks completely well and you're convinced they've got a transient synovitis, just helps you visualize it. And I've also actually found that it helps explain the parents at the bedside what transient synovitis is, if they can actually see the effusion in the hip, rather than me trying to explain it and giving them an information leaflet. So this is a 4-year-old, basically woke up, had a sore hip, wouldn't stand on it, hadn't injured herself, otherwise looked well. Again, I didn't see this kid initially, but whoever saw them first decided to x-ray her pelvis. And just for the interest of time, it looked normal. So the plan was to get some bloods, have a chat with orthopedics, and take from there. So in terms of how you scan the hip to look for an effusion, so basically, whenever I'm scanning hip, the POCUS question I'm asking myself is whether there's an effusion in the joint. Now, if there's an effusion, then obviously that's probably why they're sore. So I'm not worried that it might be something else, like anything else that's mimicking hip pain. And if they're otherwise well and not febrile and they don't look sick, then they're probably not going to have a septic joint. They're probably just going to have a transient synovitis. So in terms of how to do it, so this is the kind of position you want them in, ideally, if you can. So you want to get them kind of frog leg, slightly externally rotated. You're basically imaging the femoral neck here, and you're having a look within that joint space, so the probe markers towards the belly button here. So that's the head, the femur, that's the neck, and these are the quads muscles, and you're taking a measurement basically from the anterior surface of the bone to the posterior surface of the muscle, this bit. And anything more than 5 millimeters, or if there's more than a 2 millimeter difference between the sore side and the not sore side, is considered abnormal. This was a paper published last year, actually, looking at the kind of use of POCUS done by PGD people, and you can see, they've got really good sensitivity and specificity as well. So back to the patient. So this is her hips. So the right one, this one was the one they were worried about. So just as a comparison, again, it's useful just to scan both. Well, it's useful just to get a measurement of what the normal one looks like anyway, but also just to demonstrate to them what you're about to do. But you can see, I mean, it looks massive on this, but actually it's only like 7 millimeters, which is not huge, but it looks big on the screen. But hopefully you can see. So this again is using a high frequency linear transducer set at about 4 centimeters, and the focus is to this bit, and you can see here. So you're basically taking a measurement from there to about there, from there to there, and you can see she had an effusion in her hip. So I basically said she's got transient spinal. She doesn't need bloods. Go home. And she did fine. Similar story. So this one was a 5-year-old boy who was triaged as a knee pain without any injury. Yeah.
How do you know that's not a septic arthritis past there?
Yeah, so it's good. So the question in the room was, how do you know it's not a septic arthritis rather than just a transient synovitis? And it's a good question. So you can't tell just by looking at ultrasound, but you're not using the ultrasound in isolation. You're using it with the assessment of your patient and how they look. And actually that kid's, looked well, didn't have a fever, obs were fine. So clinically, they didn't look like they had a septic joint. There's an answer to that question. Sorry. So
can I just jump in and talk to them about the clinical decision rules on that? Is that all right?
Yeah.
So Nigel's done his literature review on this for his postgraduate stuff. So he's looked into this in a lot of detail. The first ever paper looking into this was done in 2021 in Israel, and they had really good numbers, 621 patients, where basically what they did is they applied a clinical decision rule and said that if you fit these characteristics of this clinical decision rule, and have an effusion on POCUS, then how reliably can they make that diagnosis just of transient synovitis and ultimately not miss a septic arthritis? So you had to be, in their study, you had to be between ages 2 and 8, still be weight bearing, still be afebrile, and not have any features of, lymphadenopathy or hepatosplenomegaly, which obviously makes sense. Again, they were able to apply that clinical decision rule in a vast number of cases, like above 90%. And the only time they got it wrong was in 4 cases whereby they scanned a child within sort of 12-ish hours, which can sometimes happen. And ultimately, they looked back and thought it was possibly they were rescanned and they found that they had a fusion. But those were the only false negatives. We've replicated this study, which is going to be published in November. It's been accepted. It's just awaiting copy editing now, where we did it with 140 something patients. And again, we made up our own clinical decision rule, very similar, ages 1 to 10, all of the other same features. And then how much accuracy could we apply that clinical decision rule with? We didn't miss any septic arthritis. And we could apply it in 93% of cases. And again, the 10 times we couldn't apply it, it was just that we lost them to follow up, so we couldn't definitely say they were transient synovitis. They probably were, to be honest. So again, the way to do it is to use like a clinical decision rule, much the way we do for, which kids do we LP, which kids do we bleed, which kids do we do cultures for, and ultimately, yeah, as Nigel says, the effusion alone can't, you can't look into the effusion and definitively say that it's complex and infective, although sometimes there are clues. So I think hopefully that's something that we can introduce into day-to-day clinical practice. Thanks.
Cool. I'm just going to fire through some of these because I realize that time is running out. I've got a lot more slides. So this is basically just another picture of someone with a hip fusion. So again, you can see this one's actually quite big, it's about 1 centimeter. So this was a kid who had an atraumatic right knee pain, basically. And this one was basically a 6-year-old who, this was a bit weird actually. So there was a story of he had a bit of a sore leg for a week, but was otherwise still okay and doing his normal stuff, going to school and doing his football and stuff, and was otherwise well. But then he started complaining of a bit more pain kind of the day before coming to see us, and he was limping a bit. And progressively, he actually seemed really, really incredibly sore, and he really touched his leg. Even though he was systemically well, he didn't have any fever, his appetite was normal and stuff like that. And his obs were fine. He had some kind of basic tests done, so he had some bloods and a pelvis x-ray. So the pelvis looked normal, the x-ray looked normal. His full blood count was actually not that impressive, but he had a CRP of 58. And the question was whether he had a septic joint or not, because he seemed out of proportionately sore in his leg when you were trying to examine him. So he was getting admitted to orthopedics anyway. And again, this was over a weekend, so there wasn't any kind of facility to get a proper hip ultrasound for him. And someone asked me just to come and have a look with the scanner, and I was convinced that he was going to be my first septic joint he was going to pick up, but annoyingly, this is all I saw. So it actually wasn't even that impressive. So the left side, this is the one they were worried about. So it's not the best picture quality, because actually even just getting him to try and straighten his leg, he really didn't like it. So it was a bit suboptimal, but even still, I measured it to be about 5 millimeters in his affected side and 3.4 on the normal side. So from my point of view, it was normal. He got admitted anyway, and I think there was enough clinical suspicion and concern that he might have a septic joint. They took him to theatre that day to tap his hip. And so this is from the op note. So they managed to get 4 mils of what was described as slightly cloudy fluid, which eventually never actually grew anything positive. And the next day he had an MRI, and he basically had an osteomyelitis of his hip. This is the kind of long and short of it. So again, it's pretty good at picking up effusions if you're worried about a septic joint. If it's very unusual to have a septic joint without an effusion. Not to say that I couldn't progress, but at that point, I was pretty sure that he didn't have a septic joint. And at least in this case, I was right. Right, we're just going to fire through some of these a bit more quickly. So, yeah, we'll just go over these very quickly. So basically, this is someone who fell, hurt his wrist. This is how you scan the wrist. Please feel free to have a look at this paper if you want to have a look in a bit more detail. But this is the kind of standard 6 views. So you take 3 views of each, the radius, and 3 of the ulna, kind of dorsal, lateral, and ventral. And this was a meta-analysis about using POCUS for forearm fractures in kids. Again, good sensitivity, specificity. You have 14 studies with over 1,000 patients. This is what normal looks like. So this is the dorsal and lateral, so 1 and 2 here, the radius. So that's what it looks like. This is the bone here. This is the ulna. That's what it looks like. That's the volar surface. So it tends to be a bit deeper because there's a bit more muscle in that aspect, but again, you can see the bone here. And that's what his x-ray looked like. So he didn't fracture anything, he just sprained his wrist, basically. And the reason I'm kind of mentioning this is because for injuries like buccal fractures or clavicle fractures, I mean, almost all of them don't need any kind of active management. They're just managed conservatively and sent home. They don't need followed up. So really, they don't really need x-ray. So we could just do this instead and save them hopefully a bit of time in the department and irradiating for no reason. We'll just fire through these quickly. I'll just show you the pictures. So this is what a green stick fracture looks like. You can see there's a bump here in the bone, and there's a bit of a break here. And again, this is it looking at kind of longitudinally at the very end of the clip. I think on this bit, you can see there's a break where my pointer is there. Yeah. And that's what his x-ray looks like. So you can see it there. We'll just fire through these because these are much more the same. That's another wrist. This was a, oh yes, this is a 9-year-old boy who basically ran into a lamppost the day before coming to see us. He actually had come in that evening and was observed and discharged home with a head injury, but he came back the next day because they were worried that his vision was a bit blurry and he was still vomiting. And the person who examined him thought that he might have had a big hematoma over his left forehead, and they were worried that they could feel a bit of a step. So the plan had been made to CT his head to make sure he hadn't fractured his skull, basically. So I actually just overheard this and asked him if he'd be happy to let me scan his head just for a kind of learning point of view. So this is the right side of his head, so the bit that was normal, just to show you what it looks like. So this is, you can see it's only really like 0.5 centimeter deep, but this is the bone here. You can see it's all nice and in continuity. And this is the left side, so you can see this is the big hematoma overlying it. So this is just in short axis, and this is in long. So you can see there's a nice juicy hematoma here, but actually the bone itself is intact. So And again, the plan was for him to get a CT of his head anyway, and it was normal, as you could expect. This is a paper for skull fractures. I'm just going to fast forward quickly. This is what a clavicle fracture looks like here. So again, this is a break in the bone. And in terms of how you scan that, obviously just scan the clavicle kind of anteriorly and superiorly from the top, because you want to have a look in 2 views if possible. Clavicle fractures are great. There you go. Foreign bodies. So this is a girl who over a week ago stood on a bit of glass. I did get consent from parents to use these pictures. So this is what her foot looked like here. So you can see it's actually quite bruised, and there's a bit of a cut here. Fortunately, these are not clips, but these are just pictures. So now I'm not an expert in foot anatomy, but I can tell you that this big bright bit shouldn't be there. So this is what glass looks like on ultrasound. So it's really bright. It gives you shadows underneath it. So it's just reverberation artifact. And yeah, so this is basically what it looks like. So if you see something that's really bright and shining at you, you just think that shouldn't be there. And actually on X-ray, you could see it pretty nicely here anyway. So different bits of material will have different kind of echo textures on ultrasounds. They'll help you kind of hopefully know what you're looking at. No, I didn't scan it in a water bath. She was actually fine. Sorry, the question was, did I scan it in a water bath? I didn't, was the answer. But you could. Probably would have been a bit more tricky actually, because it was on the bottom of her foot, not the top. And this was a 3-year-old who was at a birthday party and did some sort of slide on a wooden floor, and the parents were worried that she had something stuck in her leg. So this is her thigh basically. So her bum is up here and her knee down here, and this is what it looked like. So it's a bit red on the kind of lateral aspect. So she had an X-ray. This is what it looked like. So this looked normal. Can't see anything at all. But actually, when I scanned her, you can see there's actually a little smaller bit here at the top, casting a shadow. And this bit is basically a bit of splinter or a scalp for you guys that's stuck in her thigh. And this is just looking at it in short axis. You can see at the very beginning of the clip, but you can see the shadow that it casts here, that black bit. Which again, you couldn't see on X-ray. So that's what wood looks like. Where else are we at? So yeah, the evidence base is not quite as strong for soft tissue foreign bodies, but I think really just because there's not been really good studies that have looked at it. But ironically, it is actually mentioned as one of the applications in our curriculum for what it's worth. And we'll maybe just have time to do one appendix case. So I think this is probably something when I first started doing my postgraduate qualification that I wanted to be able to achieve at the end of it. When I was a ST1, I was involved in a kid who basically came in on a weekend, query appendicitis. We couldn't get a scan where I was working at the time because it was a weekend. He went home, came back 2 days later in Perth, and he was quite sick actually. He did all right in the end, but it was investigated as an M&M, and I clearly remember going to the M&M and someone, I can't remember who, but someone in the room said, because he came in the weekend, we couldn't scan him. Why couldn't we just do the scan? And I remember he or she got completely shot down at the time. And actually, on reflection, it was a very valid question, one that I didn't ask. But there is no, I mean, it's not that hard to do. It is maybe a bit more complex. I probably wouldn't start off trying to look for people's appendixes, but it's definitely, I mean, if I can do it, you can do it, is basically my take-home message. But I would say, the amount of times that I probably got to a stage where I was probably not really engaging my brain very much. Anyone who came with tummy pain, make sure their urine's clear, give them some analgesia, do some bloods, call surgeons, let them deal with it. And the amount of times the bloods get lost, the bloods are like clots, they just sit hours and hours, you have to repeat them, or the surgeons have already come to see them, they felt the tummy, and they just said, wait for the bloods back. It comes back, CRP is like 30, what are you going to do? Send them home anyway, so why did you bother doing the bloods? So my argument is, if you can scan the appendix, if you can see it and it looks normal, then I'm not going to bleed them. They don't have appendicitis. If I can see it and it looks abnormal, then they've got appendicitis. And if it's somewhere in between, then at least it gives me a bit more information to make a judgment call as to whether, they need bloods or not in the first place. So we'll probably just have time to do one of these. So this was a 10-year-old who was autistic, which actually made him really difficult to read and engage, because he was just basically really stoic. And you basically asked him to do anything, he would do it for you, and it was really hard to kind of gauge if he was actually sore or not. Basically, he had tummy pain for 2 days. You know, the normal story. He started in the middle, went to the right, but actually he was otherwise well. Had a bit of loose stool, but he's still eating and drinking. He didn't have a temperature. He hadn't had any painkillers. He walked into the cubicle okay. He was maybe kind of hunched over a little bit, but if you asked him to jump, he would still jump. And he let you feel his tummy okay, but he did seem maybe a wee bit sore. So, and his obs were fine. So actually, generally, just from that alone, I had no idea whether he had appendicitis or not, but he had some bloods done. These were his bloods. So this is had 2 or 3 days down the line. So not that exciting. A bit of a high CRP, but and a bit of a high neutrophil count, but not anything that exciting to do. And I think any other day, or anyone else who was seeing him, I think it would have been entirely reasonable just to send him home with worsening advice, because he'd never had any painkillers. He looked okay, and just come back and see how you are. Now, obviously, I'm giving you a talk about scanning for appendicitis, so clearly he ends up having appendicitis. So I'll just go over very briefly. I think Dave gave this talk last month, so obviously please refer back to that for more detail. But this is what a normal appendix should look like. So this is a kind of schematic of what you're trying to look at. I mean, the best thing to do is actually to ask your patient where they're most sore and start there. But if you're not sure where you are, start somewhere in the iliac fossa and try and get a view that looks something like this. So this is skin soft tissue here. This is the rectus muscle, which is that purple bit to the left. This is the cecum, which is a bit kind of cloud looking. This big circle is his iliac artery, and underneath it is his vein. And this is a psoas muscle, which is the green thing in that diagram. So, you know, if you're really lucky and you'll find the appendix like this, actually it was a pretty good picture that I managed to capture, just lying nicely over the vessel. So if I can pause this, I don't know if I can pause this actually. Can I pause this? Oh, yeah. So there. So you can see this bit of bile comes off the cecum, and it's blind ending. And that's, you're pretty convinced that that's an appendix. So an appendix should be, if it's normal, should be less than 6 millimeters. It should be blind ending, look like a tubular structure that comes off the cecum. Okay, and actually 6 millimeters is, you know, it's tiny. So that's why it's pretty hard to actually find if it's normal. Whereas this is definitely not normal. So that looks a lot bigger. Everything surrounding is a lot brighter. So this is described as echogenic fat, basically, and it's just kind of inflamed mesentery surrounding it. You can see this looks thickened. I think this measures about maybe 1 centimeter, something like that. This is what a little bit of normal small bile coming in here, and you can get an impression of something casting a shadow inside it here, which is a fecalith or an appendiculith, which is basically calcified poo. So even if you can't see the appendix, if you see these kind of secondary signs, you know, surrounding inflammation or a bit of free fluid, then you're worried that there's definitely something going on in the abdomen. Okay. Just a bit of evidence base. Again, there's links to these at the end, but just in the interest of time. So I'll just skip through these. So this is back to that 10-year-old I was talking about. So this is the first kind of picture. So I mean, I didn't really know where I was. So I just basically tried to find the vessels, orientate myself. They just relatively looked okay. But then if you look at this, towards the end of this clip, there's something weird. It just pops in the left of the screen here. It looks very unusual. So that kind of caught my eye. I think it comes back at the end. There, there's like a massive circular structure here, which shouldn't be normal. And actually everything looks a bit bright surrounding it. So basically I just moved a bit closer to have a closer look at that. And you can see here, this is basically what an inflamed appendix looks like. So he went on to get I say proper scan, but he had a formal radiology scan, which basically said the same thing that I had saw, and he got his appendix taken out when he had appendicitis. It's a long short of it. And there's some other stuff, but we'll just, for the interest of time, this is another appendix case, and then I think I had a lung case at the end, but we'll just call it a day. So if anyone wants to have a look at this paper yourself, you can scan this. Hopefully it should bring you to the references. If anyone got any any questions in the chat or in the room?
Surgeons are tricky, aren't they?
Yes.
So, and they complain a bit sometimes, don't they, about patients that perhaps you've scanned
Yes.
that they maybe disagree with or whatever.
Yes.
I obviously know that you're scanning a lot that are then going home because you're making
Yeah.
which I don't think they know about.
Yeah.
What's your sort of rates in terms of matching once they get to the ward?
Yeah. So the question in the room was basically trying to get our surgical colleagues on board with my scanning. So the long/short answer to that question is we are hopefully going to publish results of a study looking exactly at that question. So I've recruited some patients, Dave and Niall in Sunderland recruited some patients. We're hoping to get about 200 patients that we've all scanned and basically looked at how accurate we are. But to answer your question about here, so I've done 40 and I've picked up 8. 2 have been false positives in the case that they had a formal scan, but they couldn't see the appendix, but they were sent home, never came back. And 1 was just sent home and didn't come back. The ones that I've all called normal, none of them have come back with appendicitis. So from my point of view, I've not missed any. And in terms of how many times I actually see the appendix and is normal, for the ones that I've seen, probably about half.
Okay. So actually, if they're moaning about 2 cases where you thought that they might have appendicitis.
Yes, I'm aware that there has been some moaning, and I've addressed that by sending in my data, which actually they are going to present at their meeting at the end of the month. So,
are you going on?
I'm on holiday.
Good for you.
Any other questions?
Just lots of comments about how good your talk's been, Nigel. So well done. It's been amazing. I think I'll just say a quick line about the appendicitis thing. Yeah, it's going to be the real next thing that hopefully we can harness and really help our patients, because as you guys all know, it's negative appendicectomy rates will be anywhere between 12, maybe 15, and sometimes 20%, depending on what part of the country you're in. And I've mentioned about the GIRFT report, and just that the fact that suitably trained pediatric radiologists are more or less lacking virtually everywhere in the world, from what the evidence suggests, unfortunately, and they're often overworked, and we struggle, don't we, out of hours to get them on board. So I can assure you guys, as Nigel will say, it is a real game changer. We've had some false positives, not many out of nearly 200, but in every case we've had a false positive, they've all had surgical pathology. So we've had a Meckel's that we, naturally, my colleague thought was an appendix, and we've had an infarcted omentum, which had a lot of free fluid in the abdomen, about 10 recorded cases worldwide in the literature. And we've, so there's been some false positives, but so far no false negatives between us both. So yeah, we just need to keep going, and we'll see how that looks. And, I'm sure Nigel would be in a position to begin to show people how to do that in your department sometime in the future, once we get all the governance ironed out from it. But he's done really well, so well done, Nigel.
There's a question about graded compression. So basically, yeah, it definitely helps for scanning the abdomen. So graded compression is basically, the idea is that you hold the transducer on the abdomen to push away all the bile gas. So basically hold it down and don't release it, basically, because you want to push away all the free gas in the small bile. So it definitely does help for scanning the abdomen. And I should also say the next talk, which I'll send in a reminder about, will be on testicular torsion on the 11th of June. But I'll send a reminder. Cool. Any other questions?
I think that's everything.
Cool.
Thanks so much, Nigel. That was brilliant. I think everyone's really resonated with the cases you've shown them, so that was brilliant. Well done.
No worries.